Hello, you don't have to strugglers. Welcome to today's episode. This is going to be the season finale of season 2 of You Don't Have to Struggle. And we're going to take a little holiday break after this. But today we have some fun stuff to talk about. My name is Lisa Tannenbaum.
Hi, I'm Dr. Lee Tannenbaum. Welcome, everybody, and hope everybody's having a happy holiday season.
Today we are going to talk about what may shape up to be the end of the fentanyl era and the entrance of a new era in the world of drug abuse, of addiction, and epidemics of new substances.
This was all started by a conversation we had with a pharmaceutical rep yesterday who was asking about the incidence of xylazine in the drug supply and how we were dealing with xylazine. And for those people who may not know, xylazine is an animal tranquilizer that came out in the drug supply 2 to 3 years ago, particularly in the East Coast, coming out of the Philadelphia area. And it created very bad wounds on people's skin because when people injected it, it would constrict their blood vessels right near their injection site. And they would get very bad skin wounds, which all turned black and scarred and necrotic. And for the past 3 years, everybody's really been looking at what we need to do to get wound care programs in place and try to augment the treatment that we're giving to people so that we can address the wounds that people were getting from injecting xylazine.
Right, because it was putting them at risk for things like sepsis and all sorts of terrible outcomes. And there had always been some risk of getting infected wounds injecting any kind of substance, but it suddenly increased 100-fold.
So the issue is that as some facilities have been able to implement wound care programs, and the facilities that I work in, we looked at doing that as well. But it takes a little while to get a new program put in place and to get supplies and to get providers and to get training and to figure out what's going on. And by the time a lot of providers got those things in place, xylazine is now disappearing from the drug supply and it's being replaced by something incredibly more dangerous, which is called medetomidine.
Right. So now the person we spoke to yesterday was coming to talk to us because she had encountered providers who were just now starting to hear about xylazine and were just starting to look for information about xylazine. Whereas Dr. Tannenbaum and I, who are specialized in addiction medicine, who go to the conferences and who really try to keep up to date on all the new literature, xylazine to us is old news. So people who are just now finding out about it, we're like, oh, xylazine's already on its way out and medetomidine on the way in. So people may not have heard of this yet. So Dr. Tannenbaum, tell us what you know about medetomidine.
So just to emphasize what Lisa talked about, a lot of providers who do addiction care are doing it as a part of their practice, whereas we're doing it as all of our practices. And Lisa lives in New York and I live close to Philadelphia. So we are really on the leading edge of where new drugs are coming into the country or being created in the country because they're not necessarily being imported in. We can just create them in a lab. So medetomidine is the newest drug that's been hitting the Philadelphia market. And it's similar to xylazine, but it's 100 to 200 times as potent. And both xylazine and medetomidine work on a different system than the opioid system, although they are most commonly mixed with opiates, which the most common opiate in the world right now or in the United States is fentanyl. There hasn't been real heroin in our drug supply probably for the last 10 years. So most of the drug supply is fentanyl. And now we are seeing xylazine disappear and medetomidine come up. And let me just spell medetomidine. I'll put it on our LinkedIn page so you can see it, but it is MEDETOMIDINE.
I gotta make sure we spell it right on the
So
air.
it's medetomidine.
And as Dr. Tannenbaum mentioned, medetomidine and xylazine are not opiates. So what this means is they can have similar effects to opiates, and as we'll get into, they can have similar withdrawal symptoms to opiates, but chemically speaking, they are not opiates. So what this means is that, one, the opioid tolerance that people who are using fentanyl have developed over the course of their use will not protect them at all against a tranquilizer overdose because it's tolerance to a different substance. Two, Narcan, the emergency overdose reversal agent that works on opiates, will not work on xylazine or medetomidine because they're not opiates. And three, the treatments that we have for opioid dependence and withdrawal, which are Suboxone, methadone, and all their various formulations, will not work to keep people out of xylazine or medetomidine withdrawal.
That's correct. It's a totally different system. It works on the alpha receptors in the brain as opposed to the opioid receptors in the brain.
And your first personal experience of this, Dr. Tannenbaum, has been at the methadone clinics, where you've been telling me you've had patients who are coming in what appears to be really terrible opioid withdrawal, asking to increase their methadone dose, but increasing their methadone dose doesn't touch any of their symptoms because opioid withdrawal is not what they're experiencing.
That's correct. But they appear similar from the outside. So opioid withdrawal symptoms are typically anxiety, nausea, vomiting, diarrhea, and a lot of sweating. But they're relatively mild. People don't usually die from opioid withdrawal. If you had untreated opioid withdrawal and you had vomiting and diarrhea for days, you could suffer dehydration and may get some medical complications from that. But generally, people don't experience any significant medical complications from pure opioid withdrawal.
Right. It's classically described as the worst flu you could imagine times 100, but generally it's not dangerous.
Correct. And actually, benzodiazepine withdrawal and alcohol withdrawal, although significantly less intense than opioid withdrawal, are actually have a higher risk of fatality because people get seizures and then they get delirium tremens with alcohol withdrawal and people can die from that. But medetomidine withdrawal is like opioid withdrawal on steroids. It's severe vomiting. It's severe diarrhea. It's markedly elevated blood pressure. It's markedly elevated pulse. The people are severely diaphoretic and they are really, really uncomfortable. So the only differentiation between opioid withdrawal and medetomidine withdrawal is really the intensity of the withdrawal symptoms, which our patients always tell us that these withdrawal symptoms are terrible and intolerable. So it's difficult to assess intensity based on a patient's complaints. Are they really sweating a lot? Are they profusely sweating? Is their pulse really high? Is their blood pressure really high? Which once again can be confounded by their baseline status and the fact that people who are in opioid withdrawal also have elevated pulses.
And also a very large proportion of the patients that are at the methadone clinics, there's a lot of overlap. People don't have housing, people don't have medical care. I frequently see patients with untreated high blood pressure that I try to send them to the emergency room and they usually decline, which is just their baseline. They walk around with their blood pressure at 200 over 120 and don't feel anything because they don't have contact with the healthcare system. They're not checked and they're not treated. So it's hard to know, is this person coming in with this blood pressure because that's always their blood pressure or because they're in some kind of acute withdrawal crisis?
Right. The other discerning factor about medetomidine is that it doesn't show up in drug tests. It definitely doesn't show up on the normal opioid drug tests that we generally have available, but it's also extremely difficult to test for, even with sophisticated lab tests.
Even a very sophisticated lab test, if you could detect it, those results take time to get back, and it doesn't generally help you to treat the patient that's having the crisis right in front of you right now.
So in the methadone clinic, the way we determined that people were actually taking medetomidine, where they present to us in severe opioid withdrawal, they were already on 250 milligrams of methadone a day. They looked terrible, and we did their urine drug tests, and they were negative. And we were stuck. This didn't make any sense. If they were already on methadone at a therapeutic dose and they didn't have any other opiates in their system, and they didn't, in fact, have anything in their system, why did they look so bad? And the answer is that they were using drug supplies that were tainted with medetomidine.
Right. It's a process of elimination. Likewise, somebody who's been on 215 milligrams of methadone, which for those who don't know is a pretty significant dose, and had been on that for a long time and had been doing pretty well, opioid tolerance doesn't suddenly leap up so abruptly, right? It happens over time.
Right. They wouldn't generally appear to you in severe opioid withdrawal, even if they were continuing to use opiates. It just wouldn't happen that way.
And to come back to xylazine, since the fentanyl era of the opioid epidemic, we have been able to make and distribute fentanyl test strips, which is great. That's harm reduction. It lets people know what they're using and helps people, if they use it, to avoid fentanyl if they don't want it. And then people were able to create and distribute xylazine test strips. We have some xylazine test strips up in New York, which we're also able to give out to people, and that's really great. As you said, there's not even a medetomidine lab test, which makes a medetomidine test strip that's available on the patient end probably years away.
Correct. And it's interesting that we developed fentanyl test strips because fentanyl used to be the drug that we worried about that people were using to cut other drugs. So we had patients that were using heroin and we would say, oh my God, it might be cut with fentanyl. Or we had patients using cocaine saying, oh my God, it might be cut with fentanyl. Real world is now is everything is fentanyl.
And everybody seeks fentanyl.
And everybody seeks fentanyl because there's no heroin. So now fentanyl is really the primary drug. And now it's being cut with first xylazine. And now it's being cut with medetomidine.
And also fentanyl is in everything, but also people are seeking fentanyl because it's 100 times stronger than heroin. And they now have such a tolerance that they built by using fentanyl to the point where actual heroin doesn't work for them anymore.
If they could even get it.
If they could even get it. I have seen some in New York. It's primarily fentanyl, but you've seen heroin here and there. But people seek fentanyl because it's stronger, and for them that produces the effect that they want. And actually this week, for the first time, I had a patient come in and tell me that he's to a point that fentanyl doesn't get him high anymore.
Right.
And he is seeking the tranquilizing effect of the xylazine. And now I talked to him and told him that that's very dangerous, but I don't know if he's going to stop seeking it out or not.
So the other thing that brought this to a head is we saw a report out of the state of Delaware that we just got yesterday that Delaware was doing some sampling of the drug supply in the community. And they have reported that over the past 9 months, the number of samples that they're detecting with xylazine is markedly decreasing. And the number of samples that they're detecting with medetomidine are markedly increasing. So right now in Delaware, the vast majority of the drugs that patients are getting off the street are primarily fentanyl and medetomidine, and xylazine is disappearing.
Let's talk a little bit about the treatment side, because you and I had discussed this a little bit yesterday. So as we mentioned, the treatments that work great for opioid dependence and opioid withdrawal, which are opiate agonists, are not going to touch medetomidine withdrawal. And as we didn't really get into yet, medetomidine, and I also believe both xylazine and medetomidine are alpha-2 agonists in the central nervous system.
That's correct.
We've described this to people as being like super clonidine. If you've been in the space of opioid treatment, you're probably familiar with the blood pressure medication that's an alpha-2 agonist. It decreases blood pressure, decreases pulse, and it also has a little tiny bit of activity at the opioid receptor, and it helps a little bit with opioid withdrawals.
That's correct. Xylazine and medetomidine do not have activity at the opioid receptor as far as I know, but they are mega potent alpha-2 agonists in the central nervous system. And they're primarily used as veterinary anesthetics. And medetomidine is used in the ICU at really microscopic doses. I believe it's micrograms that they use as IV sedation in the ICU for people that need to be on long-term sedation because they're intubated or for some other reason. And the street concentrations of medetomidine are thousands of times what is being used in the ICU.
And so the only effective way to treat somebody that we think would be effective is for that person to be hospitalized and to get massive concentrations of alpha-2 agonists or similar medications. The other day you mentioned nitroprusside, which is an ancient, terrible medication that has very few indications in the year 2025.
It's for severe refractory hypertension that cannot be brought down by any other means. It does lower blood pressure effectively, which is why it's around at all. But we are having to dig that out of our old box of tools because we can't find any effective way to lower these people's blood pressure when they're in medetomidine withdrawal.
And nitroprusside is not safe. You can't give it outpatient, right?
No, it needs to be IV in the ICU, monitored. And you got to monitor heart rate, blood pressure. It's just a mess. It's not a syndrome that is manageable in the outpatient world, and it's barely manageable in the inpatient world.
And as we have seen many other times, our patient population are usually very reluctant to go into the hospital, be held there, be medicated, monitored, not be able to use their substances, not be able to do their activities. They tend to leave AMA. There's huge problems with that. They're much more likely to go out and try to use more things to make themselves feel better, which puts them at extreme risk.
That's where the medetomidine is. It's on the street. So if you're in medetomidine withdrawal and you feel terrible, my answer to you is you need to go to the ICU and be admitted for 7 days and give you a bunch of drugs. Or you could walk out in the street corner and get some more medetomidine and you'll feel better in 10 minutes. Then that's what our people are going to do.
What we're seeing is really a super turbocharged version of the opioid dependence cycle, where you can't survive without medetomidine because you feel terrible and you are sweating and vomiting, and you go use it, but it has a really short half-life and it wears out and you have to use more. We're just seeing it's going to accelerate in exactly the same way that opioid use tends to accelerate, but even faster.
And we have no treatment.
So there's
two issues that we wanted to bring up. One is the speed at which the drug supply is changing, because by the time we identify a drug and by the time we get treatments even figured out and in place, it's too late. The drug is gone. So it took us a long time to get to develop effective treatment for opioid dependence. It was 50 years from the time that the opioid maintenance treatment clinics, the methadone clinics, were started, like in 1972. So it's been a long time to get to the point where we finally have really effective long-term treatment for opioid dependence. And now the opioids are disappearing.
It's been 50 years for methadone, and then it's been about 20 years for buprenorphine. And while methadone is effective, buprenorphine is a lot safer, more manageable, and more effective in a patient population in the earlier stages of dependence. So it's been 50 years since we had any treatment that worked at all. And then it took another, 30 years after that to develop something that was safer, could be more widespread, could be prescribed out of an office, and was much more accessible.
And would be much more appropriate for people early on in their addictive disorders, so that we don't have to focus all our treatment at the end stage of addictive disorder, where it's most expensive.
And where your outcomes are much more likely to be worse.
So it's taken us 20 years since buprenorphine's been out. Now it's taken us 3 years at the very advanced programs to get some wound care treatments in place for xylazine.
And some xylazine testing that's successful.
Meanwhile, the usual physician on the street is just hearing about xylazine now. And the fact of the matter is it's going away. So in the Delaware statistics, xylazine was present in 16%. Only 16% of the drug supply that they tested. And several months ago, it was as high as 30% in the drug supply.
Now, I do want to say I don't want to imply that all of this time and effort was completely wasted. For instance, in New York, we haven't yet seen so much medetomidine. There's still a lot of xylazine around. It's going to take time for the xylazine that's already in the system to be phased out. Like, the wound care is always useful to have. Anyone injecting anything has wounds. So these things will have uses, but the target that they were aimed at is moving. The drug supply is a moving target.
Right. And we're closing the door. This is a mixed metaphor. We're closing the door after the xylazine has left the stable. And now we're like just waking up to medetomidine, and we're like, another mixed metaphor, we're like deer staring into our headlights, because we just don't know where to go with this.
Deer staring into the headlights of the closed door of medetomidine.
Correct.
It's a moving target.
It's a moving target going through the stable door after it's left the stables.
And when the door closes, there's a deer staring at the door.
That's correct. That's our metaphor. So it's very clear. So what this really pushes towards is that we need to refocus our addiction treatment from treatment of an end stage disorder to prevention, because this disease and the changing drug supply is changing so rapidly, is going to be out of control, and chasing it is never going to work anymore. We need to quit chasing it, and we need to focus on prevention.
Right. You can think of the natural history, the course of an addictive disorder, like a tree that starts from the roots, which are all these social determinants of health. There's a million different things. It's poverty and crime rates and education, access to healthcare, social support, all sorts of things. And all sorts of issues in those areas will lead into an early dependence disorder, which tends to follow a pretty similar course. And then later on, it can branch out into a wide variety of end stages. So it could be opiates, it could be medetomidine, it could be cocaine, it could be alcohol, it could be benzos. All of those disorders have different treatment programs and different potential outcomes. You want to hit them before all this divergence has occurred, at the point where we can still arrest the development of the disorder.
Right. And another potential outcome is loss of employment, loss of family, or death from an overdose.
Correct.
So It's very similar. Once again, we brought this up. It's very similar to diabetes. We used to amputate people's legs when they got gangrene from their uncontrolled diabetes. And that was really an end stage focused treatment. Or they would need kidney transplants, or they would need to be on dialysis,
or they would have retinal problem.
And now we have medications that we can really address diabetes way, 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 way earlier. And we can prevent all those complications, which is going to improve the quality of life of millions of people, as well as cost society a lot less money.
And it saves the medical time and expertise and resources that are needed to identify each individual end stage complication. Is it the leg? Is it the kidney? Is it the eye? Is it some other thing? Is it neuropathy?
And how do we deal with it?
And how do we deal with it? And each of those end stage complications needs a different approach. And sometimes they're happening at the same time.
Right.
And it's a huge mess. But if you get somebody when their A1C is just getting to 7, you don't have to deal with any of that. You've attacked the problem at the stage when it's really very simple.
Right.
And if you can get in at that point, then you're good.
Okay, so diabetes is easy because we have a simple blood test, and I can tell whether you were diabetic or pre-diabetic or maybe going to be diabetic.
And they have an instant finger prick version too.
And they have an instant finger prick version. And everybody probably knows that, now what we do is we check hemoglobin A1Cs.
And now, after 100 years since the development of insulin, now we have GLP-1s,
right,
which again are, as far as we know at this point, pretty safe, pretty effective, pretty accessible, and can hit people much earlier in their disease course.
Right. It's really a game changer for a disease that we can easily diagnose, and we can easily diagnose it pre-development of a lot of complications.
Right.
Because pre-diabetes is a real honest to goodness diagnosis. Now, the question is if people are using drugs that we cannot detect with a drug test, what criteria are we going to use to diagnose somebody with pre-addiction?
Right. Pre-substance abuse, pre-addiction. So,
well, it's not pre-substance abuse. They're using substances illicitly, but it's pre-development of an addictive disorder, which might be very close to each other depending on what substance they choose to use.
Right. So we don't really have a good answer for this question yet. We're interested in hearing if any of you have any thoughts. Clearly, this stage of pre-addictive disorder, there's some behavioral components, there's some physiological components that we probably also can't really easily detect. We're not really able to easily detect whether somebody has a dysfunction of their opioid receptors at baseline. We kind of use family history as a proxy for that. We find out that if somebody has a strong family history of addictive disorders, it's probably pretty reasonable to assume that they're predisposed on
right,
a genetic level, but we can't physically confirm that at this time.
And a lot of times, as we've talked about previously, patients that are using illicit substances lie about their substance abuse.
Correct.
So you have patients that may not tell you the truth about their symptoms, patients that have a very small window between when they might start to use a substance and when they're going to develop a significant risk for complications.
And now you have patients who are using substances that cannot necessarily be confirmed on an external lab test.
Right.
So even if you suspect, you may not have a way of confirming what you suspect they might be using.
And the only way to really prevent this from developing is to really comprehensively address a multitude of social determinants of health, where everybody has a good environment, everybody has a good education, nobody has any trauma in their life, everybody is mature as they are growing up and has access to great mental health care and has appropriate education. Not that they've been told that the correct answer is just say no, but they have an appropriate education regarding the risks of using drugs, and they choose not to do that. That seems like a very steep hill to climb.
A heavy lift for our society at this point in time.
Right.
And something else you mentioned earlier, which I thought was very interesting, is that just say no sort of scared straight campaign that I remember. I grew up in the 90s. We still had some of that at our schools. And there was a lot of talk about how marijuana is a gateway drug and it'll make you insane and it'll make you jump off a roof and it'll do all these horrible things to you. And then, as you pointed out, marijuana just got legalized.
Right.
So everyone of my age remembers, well, kids figured out that people were lying, but if anyone still believed any of that, then we went ahead and legalized it 20 years later because it was never really the truth.
Okay, so if we can't stop people from doing it and we can't detect it by a lab test, then really all we're left with is people telling us what's wrong with them, which for diabetes works pretty well because nobody feels that there's much of a stigma to diabetes. If you had symptoms of diabetes, if you have concern for you developing diabetes, you would tell your doctor and they would say, wow, that's a good clinical concern. We should test you and see whether you have diabetes or pre-diabetes. So how can we get the stigma removed from an addictive disorder to the point where our patients would come in and feel comfortable to say, I'm noticing some things in my life that could maybe possibly be related to an addictive disorder. And I'm going to tell you what I'm doing because I know you can't detect it on a lab test.
It's kind of the great project. That's kind of what everyone's been working towards who's been working in addiction medicine for the last 20 years, at least that I know about. That's also very difficult from a societal perspective.
And it's interesting once again, because I think that to a large extent, HIV has been destigmatized.
HIV is one of the most fantastic success stories, in my opinion, in all of medicine. Was an absolute death sentence, and now it is completely treatable. And there is a lot of news every year of movement towards a definitive cure. And now we see commercials on TV for PEP and PrEP, which would have been unheard of in the past.
And people come in and they know that there are dangerous practices that might put them at risk for HIV, and they ask for help in dealing with that. They want to take PrEP, or they want to use condoms, or they want to practice safe sex.
Or they want to get tested.
And they want their partners to get tested, and they want to use clean needles if they're using IV drugs. So somehow we were able to destigmatize HIV and address it as a medical problem that some people develop that can be best treated by preventing it. And we have lots and lots of measures that we can apply to help prevent HIV so that we don't have to treat it. And on top of that, we also have some very good treatments so it doesn't progress. If we're losing the good treatments in addiction because the drug supply is changing, we really need to focus on how we can destigmatize it to the point where people will tell us what they're doing so that we can try to help them prevent it from progressing.
Right.
How are we doing that?
I don't know. I don't know yet. Ask me again in a couple months. Maybe I'll have cracked it. But I also just want to point out too that we're losing the treatments of the end stage problems of medetomidine crisis. But the treatments that we have are probably still effective at that earlier stage. As of right now,
Absolutely.
People don't start with medetomidine and xylazine. They still are starting with heroin and fentanyl, which means that buprenorphine will work if you catch them early enough.
Correct.
So
if you can destigmatize it to the point that somebody would tell you what they're using so that you could get them on buprenorphine
early
and treat their opiate use disorder before they progress to the point of using illicit drugs off the street and being exposed to xylazine, that is the way to do that.
Right. The things that used to be, or that we're hoping to use as end-stage treatments have really worked better as early-stage treatment. This is going to be our season finale for season 2 because we're going to go on a little bit of a holiday break. But you, our listeners, if any of you know the answer to how we can destigmatize addiction to the point where we can catch and treat pre-addiction, that is really the million-dollar question.
That is the million-dollar question, and that's really the answer to the problem. Is we need to cut it off at the roots before we end up with problems that we can't treat effectively anymore.
Right. There's a lot of talk right now in the news about fentanyl trafficking, and if you really dig deep down into the trafficking of the fentanyl and where it's coming from and how prevalent it is, actually the fentanyl coming into the U.S. has been falling for several years.
Right.
It didn't start this year. We don't know where it's going to go in the future or whether it's going to continue to be produced in the U.S. So fentanyl, I'm sure, won't go away, but also we're going to be seeing more and more of these new unheard of substances.
But let's clarify. Fentanyl is not a natural opiate that needs to be smuggled in. It's a synthetic opiate that can be produced in a lab if you have the correct precursors.
Correct.
And the precursors for fentanyl are the same as chemical precursors that we use for a million other things.
Right.
I mean, so far, the only drug that we really need to smuggle into the United States is cocaine.
Right.
We don't have a really good synthetic cocaine, although we do have stimulants like Adderall, but we do now. Everybody grows marijuana. I can grow marijuana in my yard. I don't need to smuggle marijuana in. So cocaine is really the only drug that won't grow here I don't actually know. Will it grow in a grow house? I've never heard of anybody growing cocaine.
I don't know. I don't know. Any of our listeners, if you happen to know the answer, we're curious.
Yeah, it's interesting. Nobody grows their own coffee and nobody grows their own cocaine.
I do think that those are, I don't know about cocaine. I would have to look into the growing conditions, but I do think there are things that are more tropical that don't grow well even in the most tropical regions of the US. But I'm sure you could create an artificial environment, but I'm sure it's also pretty expensive. It may be a cost prohibition problem. If smuggling cocaine gets more and more and more difficult and expensive, it may become worth it for people to create cocaine greenhouses. I don't know.
That's really interesting that I've never heard of that. I just thought of that. Everybody grows marijuana. That was not an issue. Everybody just grew marijuana. It's a weed. It grows anywhere, but
Right.
nobody grows their own coffee or their own cocaine. All right,
Well,
we're going
well, next season we'll do botany.
We're going to
That'll
do
be fun.
an agricultural expert.
Right. We'll have to find an agricultural expert. But meanwhile, physiologically, in terms of dependence, cocaine is the least of our problems.
That's correct.
So in conclusion, have a great holiday season and great new year. Don't use any drugs off of anybody because you can't tell what's in them. And
we're looking forward to talking to you again next year. Everybody have a safe New Year's. And remember,
you don't have to struggle.